right, let's get started again. So the next session will be about measuring effectiveness. Like, how do we measure? We already talked about how to find probabilities for cost-effectiveness analysis models. We still haven't talked about how to measure costs, but I mean, we usually measure them in currency. That is easy, but how to actually find that, find the actual amounts, that's something that we're going to talk about tomorrow. But now let's talk about how we measure health and what are the various options, what are the pros and cons, and the challenges in here. To measure health outcomes, we have a bunch of options. We can either measure health gains or losses in terms of the so-called natural units. In that case, we would call such analysis that measures health gains in natural units. And by the way, a natural unit would be, for example, cases of flu prevented, number of cases prevented, or number of myocardial infarctions prevented, number of life years saved. This type of analysis would be called cost-effectiveness analysis, which is a term that I've been using pretty much constantly up to now, and I will continue to do that. When we measure health in these so-called quality-adjusted life years, technically speaking, that type of analysis is called cost-utility analysis, but I would still call it cost-effectiveness, or that's what I'm going to do. Sometimes we actually can translate the health gains into monetary terms, into rupees, into dollars, into whatever currency is appropriate for the analysis. And then we would turn the analysis into a cost-benefit analysis. But that is difficult, so I will not talk about that much. We will talk mainly about the natural units and the utility values. Obviously, the choice of the metric, how to measure effectiveness or health gains, depends on the objective of the study, of the perspective, of the interest, depends on the interest of the decision maker. So there are many reasons why to choose one metric over another, but there are also each one of them comes with some limitations and some advantages. So we'll talk about that. All right, so natural units, those are the most simplistic metric for the particular disease or condition that you're studying. So in our example with vaccinations, number of flu cases prevented would be a good metric. If you're evaluating a new MRI machine, it's a diagnostic testing device. So you would like to see the number of correct true results compared to the old machine that sometimes got something wrong. In general, natural units are fairly easy to measure. But the thing is that, let's say you will do the analysis using natural units, and you will find that the ICER is 100 rupees per case of flu averted. That seems like a good deal, but do we know that? What if it's 10,000 rupees per flu case averted? What if it's 100,000? That's really we would need a specific cost-effectiveness threshold that would tell us that each case of flu averted is worth at least 100,000 rupees. So we would essentially need, for each natural unit, we would need its own specific cost-effectiveness threshold. And with all the many different natural units that you can think of, we would need a threshold for every single one of them. which is difficult. That is the huge advantage of QALYs. If we can convert every health outcome into this like general unit of health, we need just one cost effectiveness threshold. There may be problems even with that one, but if you had 100 different thresholds, you would have 100 different problems. So the main disadvantage of natural units is exactly this. Another disadvantage is that, let's say you will find that this flu vaccination has some ICER in terms of rupees per flu cases averted, and you would like to compare that ICER to a different intervention that has nothing to do with flu. It would be maybe myocardial infarction prevented, and it would be a different monetary value per each case averted, but you cannot easily compare which one buys more health if they're not on the same scale. Another still considered a natural unit is life years saved. We don't talk about quality. It's only about the number of life years saved. Again, it's relatively easy to measure. This unit is general enough that it can be used in many interventions for different diseases, and then you can compare the ICER across different interventions for different conditions. So that solves at least some problem with at least some of the problems of the natural unit that I talked about before. But the thing is that not all interventions save lives. Some interventions alleviate pain. Some interventions lead to better diagnostics. Some interventions just like improve the general quality of life, but we still live the same number of years. So that is an issue. And so ideally, the best general measure would combine mortality and morbidity into one metric. And that's exactly what the QALY does. So you can think of a QALY as a two-dimensional metric. On one axis, we have time. Time the person is alive. Starts at some point until death. And the other dimension is quality at each particular time in life. Then the QALY, the quality adjusted life year, would be the number of years lived essentially the number of years lived, adjusted for the quality at each particular time. So you can think of it as the area under the curve, essentially the integral of this function. In this example, we have this person, we start our analysis here, and the person has almost perfect quality of life. Not exactly one, but pretty much there. Lives with this, so this person lives for a while, but then her health deteriorates quite a lot. Lives in that quality for quite some time. Then she gets a little worse, lives in that health state for quite some time, and then she dies. So the QALY would be this blue shaded area. While with the intervention, we can, for the same person, could live in this almost perfect quality of life a little bit longer, then she gets a little worse, but lives much longer in this quality of life. She gets worse until she dies. So in that case, for this person, the QALY, the amount of quality adjusted life years would be the sum of the blue shaded and yellow shaded area. The yellow shaded is essentially the incremental gain in quality adjusted life years. What I would like to point out here is that if we forgot about quality for a second, in this case, we actually would see a difference even in the life years themselves, even if we don't consider quality. But that's not always the case. Let's take this example. We have time on the horizontal axis again, we have quality on the vertical axis again, and we have two patients with some heart condition, and this Mr. Smith receives cabbage surgery, and Mr. Jones receives just an angio. So Mr. Smith is the full line, Mr. Jones is the dashed line. So if we start with Mr. Jones, his quality will first get a little bit worse immediately after the procedure, but then he will get better, but then he will get worse again, and then he will get better. While Mr. Smith, cabbage is a much more substantial surgery than just angio. So his quality of life will be less in the first weeks after the surgery or after the intervention. His quality of life will be actually less than of Mr. Smith. But then the quality will improve substantially and pretty much stay there. The point here is that if you looked only at survival, life years gained, both of them lived to at least 8 years, then we stopped following them. So there is no difference in survival or in mortality. If you looked at quality of life in immediately after the surgery, Mr. Jones with angio is actually doing better than Mr. Smith. But overall, the area under the curves, is much larger for Mr. Smith. So the quality adjusted life year allows you to adjust for quality at each point in time. And it can change. It doesn't always have to go down. It can go down and up again, depending on how the patient health progresses. So the QALY combines benefits in life expectancy with improvements in quality of life by quality adjusting life years. So it combines gains and losses in both quantity of life, that's the mortality or survival, and quality, morbidity, sorry. The huge advantage of a QALY is that it can be a common metric for many conditions. And then we can easily compare an ICER of one intervention versus another, and an ICER of a totally different intervention for a different condition, and find which intervention can buy us more health, or for the same amount of money, which intervention can buy us more health, or if we can buy the same amount of health for less money. Then we can easily compare the results, but the problem is that they're not so easy to measure. And they also can be somewhat controversial, as you will see in a moment. So to calculate the QALY, we need measures of the two dimensions, right? We need the dimension of time, which is either the time horizon of your study or life expectancy if you have a lifelong type of analysis. But also you need the quality piece. And once you have the quality, the utility, it usually ranges between 0 and 1, where 0 means death and 1 means perfect health. And anything between that, in any condition that is not perfect health, has a value somewhere between 0 and 1. Once you have the time dimension and the quality, you just multiply the two. Of course, only for the period of time that quality applies. As you could see, the quality can vary over time, so then it would be essentially the area under the curve. The utility values usually vary by age, sex, and health status. And that is important to keep in mind, that broadly generalizing, women may value certain health conditions differently than men. Young people value certain health conditions differently than older people. And people living with certain health conditions may value them differently than people living without them. One of the somewhat more extreme examples is blindness. Those of us who are not blind cannot even imagine living, being blind. But people who are blind, they're like, it's okay. Like, it's not ideal, but they get by. So it's really difficult to think about about all of the variation that is how each of us values certain health states. So I already mentioned that the area under the curve. Just to make sure, more QALYs are better. That means either longer life or same amount of life but better quality. One thing that some people don't like about QALYs is that they have this so-called interval property. That means that, as I have on the slides, like going from quality of 0.9 to 1, perfect health, is valued the same as going from 0.3 to 0.4. Is that appropriate? I don't know. Maybe it is, maybe it's not. Another thing is that gains in QALYs are treated equally and doesn't depend if... So let's say if we gain 10 QALYs by implementing an intervention. It can be either 10 people gaining 1 year of life in perfect health, or it can be one person, the remaining 9 would die. One person would gain 10 years of life in perfect health. Is that the same thing? It's hard to answer this question. But that's just a trade-off of this metric. So now I would like to hear your opinions. Opponents of the QALY measure usually argue that QALYs favor young and healthy people because they have more QALYs to gain. If a young person is in the risk of dying, saving that person has a huge potential of gaining a lot of quality-adjusted life years in the future. While saving a person who's already 70, maybe 80 years old, they probably won't gain that many QALYs in the future if we save that person. So that is one of the major criticism of the quality-adjusted life years. But isn't this what we want? Should we want to prioritize younger people? I know this is a somewhat controversial question, so I am happy to hear some pushback. I'm not saying that this is what we want. I'm just asking. What do you think?
Utility indicator, the quality adjusted life is based on the quality of life, the scope mainly. If any, I don't know what the perfect estimate of that quality of life. Again, your graph, if the immediate is low, then it's increasing. What time point you have to get that quality of life score? For example, immediate after treatment, or we want to wait and get the quality of life.
Well,
otherwise,
to get a precise estimate, you would ideally need the estimate at every single time point, which is what you would not get. But like when you think again about the state transition models, you can, by the nature of the disease progression, you see how often people change health states from being miserable to feeling better. And then you can obtain a utility value for feeling miserable and a utility value for feeling better. So of course, like you will not track everyone in real time, At least not with our technology is getting there, but we're not quite there yet. But there is a way how to approximate for that.
How do you assign numbers to quality?
We'll talk about that in a bit.
To add to this, like as you said, QALYs depend upon the age, sex, and the X status. So doesn't this question taking account of age also? When the young age, that means it's
the variation is not so much. So let's say if an older person values certain health condition at like 0.9, a young person can value that same health condition at 0.88. It will not really solve the huge discrepancy between that a 10-year-old child has probably 70 years of some decent quality of life to gain, but an 8-year-old has maybe 5.
I think it relates to ethical position and equity. What do you think about the equity? That is the stands. We have to take some stand and then decide what is better.
In limited resources setting, you have to go by who can be, yeah. So put your resources where it will bring in some benefit to the society. And so I think, yeah, it's not fair to the older people, but that's the way it goes when there is economic limited resources. We take these decisions all the time in our clinical practice when we say, okay, we would write off our bills on a younger person much more than with the older person. Because based on the fact that the younger person would probably physiologically do better.
Yeah.
May not be right. May or may not be. The ethical part of it is not what we're talking about. But if you look at the economics of it, that's what we take up.
There's other.
WHO and EORTC and different organizations have developed the quality of life scores for different cancers, benign diseases, after surgery. So do you use the score of that quality of life for calculating quality?
So there are many different ways how to measure the quality dimension, and I'll talk about that in a second. So are there more opinions on this question on the screen? In a second.
Slightly different thing, because when you say quality, it gives me a unit, but I don't know what it means clinically. If I use a clinical unit, a unit of measure, let's say reduction in pain score or something like that, or reduction in psychopathology scores or something like that. There are statistically significant changes and there are clinically significant changes. They're two different things, because sometimes the score may drop by 5 and it's statistically significant, but it really doesn't mean anything clinically at all. So in that sense, for me, quality by itself doesn't mean much. It gives me 1 quality or 2 qualities or 3 qualities. But if I can use a clinical unit, it means more to me because it makes some sense.
This question would actually work with just life years. If we forget about quality, if we save a young person, they have a lot of life ahead of themselves. An older person, not so much.
But I think one of the issues with this is if you look at it as just young and healthy, then it makes sense. But there are lots of young people with non-communicable diseases, then those also get disenfranchised by this model, right? If you look at as the, I don't know whether I'm explaining myself clearly. Because there are 2 components to it. There is the young and healthy, but there's also the young with more chronic diseases.
Absolutely.
So just as the old gets disadvantaged from an economic perspective, then the people with more chronic illnesses will also get disadvantaged if we don't look at
So in one way, this I've also seen this argument that people with chronic conditions, they're not worth much, right? Because they don't have as many qualities. But you can flip this and you can think about it, well, with good interventions, they have a lot of qualities to gain. While someone who's in perfect health, they cannot really like improve much more, right? They're at the ceiling already. I don't think it necessarily discriminates against people with disabilities or people with chronic conditions. Thank you.
By default, if we are going to look at young versus elderly, it's going to be tipped in favor of the young because we are looking at the x-axis, which is time. But I don't think that should. By default, it's going to favor the young because we have the x-axis as time, and we are going to look at the area under the curve. But this is at a mass level. I don't think this can translate into what I do in my clinical practice as an individual patient that I'm treating.
Absolutely.
That at that moment, I don't really think any of this directly translates to the quality that my patient is going to see. Because I'm not really comparing, if I say a coronary artery disease patient, when I'm treating him, in my mind or in my treatment, I'm not really comparing him with a young adult who never had that disease. I'm comparing him with another person who had, so it could be Mr. Smith and Mr. Adam that we had over there. If not Mr. Smith and his daughter, I'm not really comparing that. So I am not sure whether, as a statistical tool or as a measurement tool, quality might be favoring the young. But in clinical practice, does it really translate into anything for me? When I'm treating a particular condition, I'm comparing another person having similar condition. That's how I would take that.
Yeah, like for a single person, the outcome will always be one or the other, right? So that's the thing that you just have to think about the expectation. Is the person expected to live longer? You don't know. Maybe the old person will live for 30 more years and the young person will live for 2. But in the expectation, the young person still has more life to gain. Right?
So if I rephrase myself, is this a tool I use in clinical decision making or only when I'm analyzing my data for maybe research purposes?
In general, I think that cost-effectiveness analysis is mainly used for population studies, not for any single given individual.
But in one way, let's say, take the example of osteoarthritis and knee replacement surgery, right? So one would probably, would be more forthcoming to do this on a patient who is 55 or 60 years of age, then do the same surgery on somebody who's already 85 or 90 years of age, right? So that, or maybe the quality of implants, dental implants. So somebody who's a little younger who probably would want to go for a costly implant, which is likely to adjust with the decreasing, BNP of the jaw. And somebody who's already 95 years of age, he would want to, just have an implant which would see him through for maybe next 3 to 4 years.
Yeah.
So of course it doesn't translate mathematically or very objective to this, but these kind of things one always probably would have a kind of back of his mind before taking these decisions. Both the doctors as well as the patients.
Thank you. Yeah.
Another flaw which we see is this mostly especially in cancer treatment, mostly the age group which is taken into the treatment itself is less than 60 years. So most of the efficacy values which we get will be depending upon a younger actually group. So we are not looking at the elderly what is actually happening. So really, if you want to extrapolate this data, you should need an efficacy data of the elderly population, and then do that. Then maybe even the QALYs may be less, but the ISA may be better in that way.
Indeed.
Separately doing an elderly group rather than doing in the combined population.
Yep. That absolutely makes sense. That's the thing, that we do studies on very limited populations and then extrapolate to everyone. And especially like the studies that are done on men that are about, women's uterus, and the studies are still done on men, just make no sense to me, but that's how it is. Did you also wanted to add something? No. All right, so to give you some peace of mind, the thing is, so it is true, in expectation, a young person has more life, more quality-adjusted life to gain. I don't think this is working again. Is it?
Yes.
Okay. So the young person has more life to gain in the expectation than an older one. But what also has the young person to gain is a lot of costs. Not so much for the older person. Of course, like most medical care is delivered in the older age. So the first reaction is usually, but old people are more costly than young people to treat. But if the young person that we save lives all her life until old age, they will also get old and incur all those costs. So when we introduce costs and actually calculate the cost effectiveness ratio, this doesn't actually matter that much. So one thing that I also would like to mention a little bit more about discounting. So as I mentioned before, QALYs do not, it's essentially this like one huge metric, and it doesn't matter if one person gets all of the QALYs versus a few people get some of the QALYs, or all of the people get just like a little bit of QALY here and there. And even though it doesn't matter at the first sight, it actually matters when you introduce discounting. And so let's take this example. We have 5 people, and if we do, they have some health condition, and if we do intervention 1 on them, every single one of them will gain 2 quality-adjusted life years. So in aggregate, this group of 5 people will gain 10 years of life, right? While in intervention 2, the first 4 patients will die immediately, but the last one, the 5th one, will gain 10 quality-adjusted life years. So in that group, or under that intervention, this group of 5 patients still gains 10 quality-adjusted life years, right? But they're not exactly comparable if we introduce discounting. So if we have 10 years of life, which is the maximum that we can gain in this example, each year we gain 1 year, that's the future value of it. So a total is 10. If we assume a 3% discount rate annual, the value of the first life is, the present value is 0.971, and it keeps decreasing, and the 10th year of that life is valued at 0.74 QALYs in the present value. So because in intervention 2, one person will gain all these years. So in total, they will gain the present value of their life gain would be 8.5 quality-adjusted life years. While in the other group, where everyone gains 2 years, every single one of them will gain these first 2. So we will calculate the sum of the 2 times 5, and so we get 9.5. Present value of 9.5 quality-adjusted life years. So the intervention 1 would actually be valued as better, because the present value of it is higher than intervention 2, even though in both scenarios we gain 10 years of full quality-adjusted, but 10 years in full quality, essentially. So we talked about QALYs. I will not talk much about Dalys, but I would like just to mention them, that they exist. So QALYs means quality-adjusted life years. Dalys mean disability-adjusted life years. It's a very similar concept. It's somewhat a complement of a QALY. When I said that more QALYs are better, because more QALYs means longer life or better quality or both. Dalys, it's the opposite case. Fewer Dalys is better because each Daly means a year lived with a certain disability. In this example, so we have a healthy person who gets sick and then lives with some disability. So these are the years lived with disability. And the disability also makes this person die a little bit earlier than he or she would be expected to pass away. So the person lived these years with disability and then lost these years due to the disability. And so the disability adjusted life years would be this part, roughly. We can, so maybe let's take, I personally like this illustration a little better than this one. So right now we have a person, this dimension is time, this dimension is the quality of life, and this person lives in perfect quality, then gets a little worse, little worse, little worse, little worse. This is what it would be expected if the person didn't get the disease. It's just that quality of life slowly decreases with age. So let's say now the person gets sick at this point. So the quality of life decreases immediately. The person lives with this decreased quality of life for some time, but then dies. So QALYs would be this green shaded area, and Dalys would be the complement. Because the person lived in this period of time, the person lost this quality of life that would be expected under normal conditions without the disease. So the person lost this amount, this quality, but still lived. But then the person essentially lost all this quality due to premature death. Some cost-effectiveness analyses, especially those done on developing countries, use Dalys instead of QALYs. So it's good to be aware of them. There would be a different willingness to pay threshold for a Daly because it's a different concept, but also like it's fairly similar. In the idea is similar. All right, so I have just one slide on. Oh, okay.
Daly is calculated based on only mortality.
I'm sorry.
This is only mortality based. The Daly is estimated based on mortality. Based on life expectancy.
Yeah, life expectancy. So mortality, but also the expected quality of life at different stages of life.
So this is quality of life also.
Yeah. So quality is this dimension, and if the person didn't get this disease, this particular disease we're studying, we would expect them to live this long, but the quality will be slowly decreasing over time. So it also takes into account the quality, but in a somewhat different way.
So he had a reduction in quality and an increase in that.
So this disease led to the fact that this person was expected to gain this many QALYs if they didn't get sick, but they did, and they had this reduction in QALYs, which is essentially the Dalys.
So
due to that reduction in quality.
Well, it's due to the disease. And
So saying Bali is the green part, and we have to say that Daly is the
yes.
which is beyond it. How can you be it's because
Daly is beyond it. Reduction.
Yeah, like you need to know the expected quality of life had the person not had the disease.
just one more question. What if with the reduced quality of life, the person actually survives till the normal life expectancy, but with a reduced quality? Let's say this green shaded portion.
So you're saying the threshold all the way here. So then the Dalys will be
So it's not necessary that the person dies early, he can survive for life.
Yeah.
As long as there is any net reduction in quality, it's all fine.
Exactly. So this diagram illustrates that there are some Dalys equal to the years lived with disability plus year lost due to the disability.
So YLL can be 0 also.
Yeah, exactly. It can be 0. All right, so for life expectancy, for the general population, we usually use life tables that we can find on a website, usually of a statistical office. I believe there are some demographers in this room, so you probably know this better than I do. But for certain health conditions, to estimate the reduction in survival or in expected mortality, you would have to again look into the literature. There are studies that look at different survival curves for different conditions, or with how different interventions alter the survival curve. And so those would be the types of studies that you would look for to find estimates of reduction in life expectancy or improvement in life expectancy.
Could we go back to the previous slide, please? So, if supposing the person had disability and he did not die,
Yeah.
so then what you say would be damage?
So, if the person didn't die, this green area would go all the way here, and then, let's say they would still die at the same time when they were expected to. So the value would be just this area.
So, do we then want to say that quality is more, even though the quality is not good?
I don't think, you should not compare Dalys and QALYs. They are not, you don't want to compare, this person had more QALYs than Dalys. That is not what we want to do.
It's like actually, if there is 0.5 quality, then actually 0.5
Exactly. If you increase one, then you decrease the other one, and vice versa.
The WHO, they have given again scores like DALY 0 to 1. The 0 is total disability and mild moderate disability will go.
I think you're talking about just the quality dimension, and that is what I want to talk about now. How do we get the quality dimension?
Can't that quality there at the present point without death also? Can somebody be bedridden? Even could be a vegetative state?
We'll get to that. Hang on a few minutes. So, QALY, let's go back to QALYs. It's a two-dimensional metric. One dimension is the life expectancy or time in general. The other dimension is quality. And the we usually focus only on health-related quality of life. There are many other factors that you can argue that affected your quality of life, but for economic evaluation in health, we consider only health-related quality of life. The fact that your house got flooded or stuff like that, that's not included here. They usually range from 0 to 1, where 0 represents death and 1 represents perfect health. Just be aware that only very few interventions can take you back to the quality of life equals to 1. Especially older people, they can hardly ever get to perfect quality of life. But they can, certain interventions can at least get the patient to their expected quality, given their age, sex, demographics, socioeconomic status, and so on. The quality values have already been estimated for many diseases, for many conditions. There are catalogs. I'll also talk about that a little bit later. So for many conditions, you can just look up the particular condition and find the value in the literature and just plug it in. If it's not available, I will talk about certain tools how to actually estimate it. All right, so another class discussion. So the quality dimension is measured on a scale from 0 to 1. High values mean high quality, low values mean poor quality, 0 means death. Can quality be negative? Or in other words, is there something worse than death? Well, quality is always positive because we force the quality metric to be bound between 0 and 1, where 0 means death, 1 means perfect health. But is there a health condition that's even worse than death? So why do you think, maybe let's go first to the vegetative state. Why do you think that's worse than death? Let's forget about costs. Now we're talking only about the quality of life.
Quality of life. It is that person's quality of life, and it impacts the quality of life of the caregiver. So it brings
That's a spillover effect. Now we're talking about the particular person. Do they feel any pain?
Death has no pain.
That person is in. If he or she wants death more than what the state he or he is in, so that means that current state in which the person is a negative quality.
So let's say if we allowed negative quality, how far can we go? Would it end at 0.1, -1, -100, -1? Why -1?
0 to 1 is scale.
Yeah. So let's say if we had the scale from -1 to 1, 0 means death, then keeping people dead or killing some people may be cost effective compared to keeping them in certain health states.
That is the argument for you.
That's why Hitler did it.
Will they have a better quality?
I think it should be 0 to 100 so that you have more options.
Well, you can just scale 1 to 100.
Yeah. Because you see, 57 may be better, better than 51. And
Yeah.
0 to 1 both will be 0.5.
No, they would be 0.51 and 0.57.
No, but a common person, non-mathematical background person, cannot give 0.57. So you just say 0.5. So if you have 0 to 100, you have more options.
No, I disagree with that.
No, common person can't count.
Between 0 and 1, you have infinitely many numbers, same as between 0 and 100.
Based on what I just said, it might be negative, but then that negative is transitional. It is not fixed because quality of life changes. So that is why we don't, I think, score quality of life as negative. Because once negative is not always negative.
I think countries which accept euthanasia, they accept that some terminal illnesses are worse than death. So the judge allows them to voluntarily be put to death because he believes that it's better to be dead than to be alive in that state.
But even in that state, we feel that death is never under the control of someone. So we always hope for something better, and that's why euthanasia is not legalized
I'm
everywhere.
saying some places they seem to value that.
That logic might be used, but generally not used. Death is something which is not under our.
Yeah.
Just a thought, I'm not saying this is right, but someone said that anything where death is better. So I'm just thinking, someone who's planning suicide, deliberates with harm, severe deprivation. I'm not sure, I'm just thinking, but is that something which can be called negative? I'm not sure because I don't know.
Yeah, this is difficult. Like there are difficult ethical questions here, and maybe let's keep moving. I will just summarize what is the overarching theme that I've heard here. It seems that most of you can imagine some health state that is worse than that. Again, for practical reasons of modeling, it's difficult to go into negative values because then it solves some problems but introduces 10 times more other problems. And so therefore the current recommendation and the current practice in cost effectiveness is that the utility values have to be within the range of 0 and 1 inclusive, where 0 means death. And even a horrible state, which is when the person is actually not in vegetative state, is aware of everything but is in horrible pain, that would be a value that's more than 0. Maybe teeny tiny, not much, but that health state would be valued as positive. All right, so how do we get the utility values? Now we get to your point. So we can just ask people to rate how they would rate their health condition, the utility of the current health state, on a range from 0 to 100. And after we get their estimate, we would just divide it by 100 to get it on the 0 to 1 scale. This is the easiest way how to get the estimate. The problem is that it's so subjective and really difficult to tease out the signal, especially because the people generally don't think about like, oh my god, this morning I woke up, my quality is 0.8 or 80. Like, people don't think like that. And so when we ask them these questions, they don't really give reliable answers. So this is obviously like the most simple way how to get a utility value, but there are better ways to do it. One of them is an instrument called EuroQAL, or sometimes you usually see the abbreviation EQ5D. It is a questionnaire that fits on one page. It has essentially 5 questions. One is about self-care, one is about mobility, one is about usual activities, one is about pain and discomfort, and one is about anxiety and depression. And each of these questions, it's a multiple choice question. Each of them has 3 possible answers. And it is that I experience no problems doing, self-care, some problem, or major problem. And you can present this questionnaire to patients and ask them, how would you, imagine you are experiencing this condition. Do you think you would experience some of these, how would you answer these 5 questions? When you collect the questionnaires, you have to pay EuroQAL. They already established a reliable set of weights and weigh each answer with the weights that they keep secret so that you don't have access to them. But if you pay them, they will process your data and spit out the average utility value with some range of uncertainty, of course. So this is one way that is much more reliable than the simple visual analog there are essentially 243 combinations, like 3 to the 5th power, because we have three levels of answers and 5 questions. So there are 243 different combinations of a health state. But there's also, the EuroQAL also assumes that a person can be unconscious, therefore unable to answer the survey, and the person can be dead, also unable to answer the survey. So a total of 245 different health states. And then they convert it to a single summary index, which would be the utility value by attaching weights. This system was originally developed in the UK because the National Institute for Healthcare Excellence, or the NICE Institute in the UK, does a lot of these types of analyses. But right now there are many other countries. Last time I looked, there's India is not an option yet. But last time I looked was probably, well, I looked yesterday, but it was an old document. So maybe that changed.
They are doing India 1 or 2 years.
Really? Excellent. Thank you for that. There are other instruments. EQ5D is not the only one. I'll just mention there is a Health Utilities Index. This one has 8 attributes and 5 to 6 levels of answers. The EQ5D had 5 questions and 3 levels. There's a Quality of Wellbeing Index. So there are all these different metrics that are based on a similar idea. But I will not go into the details. Another one is SF36. The number 36 indicates that there are 36 items that can be grouped into these scales, and they can be further grouped into 2 main summary measures of physical health and mental health. But it's essentially, again, like a survey that is distributed to patients and healthy individuals. But the current gold standard in assessing utilities are so-called preference-based measures. Sometimes they're called classification systems. And study subjects, to obtain these utility values, study subjects are asked to make judgments about the value of health states. And the visual analog scale actually falls under this type of measurement. But as I mentioned, that's the weakest one by far. The standard gamble is theoretically the best way how to obtain a utility value. And I will shortly show you a video that explains exactly what it means. Maybe, you know what, let's do the video now, and then we can talk about it a little bit